I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this particular session, I'll be discussing the quiz which I have posted on 10th of May on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So every day I'm posting the quiz on my Telegram channel, and on the subsequent day I'm sending the explanation as well. So as a part of it, let me discuss the first question. Bulbar paralysis refers to upper motor neuron paralysis of cranial nerves 3 to 12, upper motor neuron paralysis of cranial nerve 9 to 12, lower motor neuron paralysis of cranial nerve 9 to 12, lower motor neuron paralysis of the cranial nerve 3 to 12. So the word bulbar paralysis, it means the lower motor neuron type of paralysis. And which cranial nerves are affected in case of bulbar paralysis? That is, the cranial nerves 9 to 12 are paralyzed in case of the bulbar paralysis. And these cranial nerves 9 to 12, they are present mainly within the medulla oblongata. Now, if you see the detailed explanation of various etiologies and the clinical features, in these patients with the bulbar paralysis, right? So as I have said you, 9, 10, 11, 12. So these are the cranial nerves which are being paralyzed. Then what will be the clinical features that you come across in patients with the bulbar paralysis? So because of the paralysis of 9th and as well as 10th, the individual will have dysphagia, reduced or absent gag reflex, slurring of the speech, aspiration of the secretions. There will be also dysphonia, dysarthria, and drooling of the saliva. And the other manifestations that you come across is nasal regurgitation, difficulty in handling the secretions within the mouth, the speech, it lacks the modulation, and there will be also difficulty with consonants, and there will be atrophic tongue because it's a lower motor neuron paralysis. And whereas the jaw jerk, it will be normal or absent jaw jerk. So these are the features of the bulbar paralysis. Now, what are the etiologies that will be causing the bulbar paralysis? Usually, it is the pathology within the brainstem. Either it is a brainstem stroke or tumor, because the cranial nerve nuclei are present within the brainstem. So brainstem pathologies, particularly medulla oblongata, will cause the bulbar paralysis, which is nothing but lower motor neuron paralysis of 9th to 12th cranial nerves. And degenerative disorders like amyotrophic lateral sclerosis. See, amyotrophic lateral sclerosis, it is both upper motor neuron and as well as lower motor neuron involvement. So lower motor neuron component of amyotrophic lateral sclerosis is the one which is responsible for bulbar paralysis. Guillain-Barré syndrome, that is also a type of lower motor neuron type of paralysis. And the genetic disorders like Kennedy disease, then Fazio-Lon syndrome. So these are the genetic diseases which are responsible for bulbar paralysis. Then how do you treat these patients? As such, there is no specific treatment, or you need to treat the underlying condition which is causing the bulbar paralysis. And you need to give the medications which are required to control the drooling of the saliva. Now, we have some anticholinergic drugs like glycopyrrolate. So glycopyrrolate, it is used whenever there is excessive drooling of saliva. And like you need to place the feeding tube because the individual has dysphagia, there is difficulty in swallowing. And you need to advise the speech and as well as language therapy because the patient is having dysphonia or there is difficulty with consonants. So this will be the treatment for bulbar paralysis. So remember, bulbar paralysis means lower motor neuron paralysis of 9 to 12 cranial nerves. Etiologies are mainly brainstem stroke pathology, amyotrophic lateral sclerosis, Guillain-Barré syndrome, and genetic disorders. And the symptoms that you will have is mainly because of the involvement of 9th and as well as 10th cranial nerve and even 12th cranial nerve where you have atrophic tongue. Treatment, you need to treat the underlying cause. So that is about the bulbar paralysis. Then the next question is about the pseudobulbar paralysis. What is that refers to? Upper motor neuron paralysis of cranial nerve 3 to 12, upper motor neuron paralysis of cranial nerve 9 to 12, lower motor neuron paralysis of 9 to 12, lower motor neuron paralysis of 3 to 12. So pseudobulbar paralysis, if you see, it is the upper motor neuron paralysis, whereas bulbar paralysis, it is the lower motor neuron paralysis. So pseudobulbar paralysis, where it is upper motor neuron paralysis of the cranial nerve 9 to 12, that is what is your pseudobulbar paralysis. So these patients, they have upper motor neuron involvement in case of pseudobulbar paralysis. Now, very, very important questions that will be asked is the differences between the pseudobulbar paralysis and as well as the bulbar paralysis. So pseudobulbar paralysis, that will be upper motor neuron pathology, whereas bulbar paralysis, it is the lower motor neuron pathology. So if you take the reflexes, in case of pseudobulbar paralysis, which is an upper motor neuron paralysis, all the reflexes, right, they are exaggerated. You take gag reflex, you take jaw jerk, they are exaggerated. And what will happen to the tone in upper motor neuron paralysis? It is the increased tone, spasticity will be there. So that is the reason why tongue, if you take the spastic tongue, and the speech, if you see, because of the spastic tongue, you have spastic dysarthria. And within the limbs, you have all the upper motor neuron signs, exaggerated reflexes, and as well as spasticity. And labile emotions will be there, or emotional disturbance will be there in patients with pseudobulbar paralysis. And etiologies are mainly cerebrovascular accidents, multiple sclerosis, and motor neuron disease of upper motor neuron type. Okay, like primary lateral sclerosis. Whereas in bulbar paralysis, you will have all the element features. The reflexes will be absent. And you will have the fasciculations in lower motor neuron paralysis. And that fasciculations will be seen over the tongue, right? And even the jaw jerk, it may be normal or absent. And the speech, it is a nasal speech because the tongue is like completely paralyzed. Element signs will be there in the limbs, and emotions, they are not disturbed in bulbar paralysis. There will be normal emotions. Whereas the causes, if you see, motor neuron disease, Guillain-Barré syndrome, poliomyelitis, brainstem infarction. So these are the conditions where you have lower motor neuron involvement. Okay, so that will cause the bulbar paralysis. So this is the difference between pseudobulbar and as well as the bulbar paralysis. Very, very important slide. Next, you see the next question. Which of the following is not the feature of the extramedullary tumor? The options are early corticospinal tract paralysis and signs, root pain, asymmetrical weakness, sacral sparing. So if you take the corticospinal tract, it is present in the lateral part of the spinal cord. So this extramedullary tumor, it can cause the compression of the corticospinal tract, and there will be early corticospinal signs and as well as the paralysis, and this will give rise to your upper motor neuron type of paralysis. And this extramedullary tumor can also compress the peripheral nerve, causing the root pain. And this extramedullary tumor will also cause the asymmetrical weakness. But remember, this extramedullary tumor will not cause the sacral sparing, right? So there will be early sacral involvement, right? There will be early sacral involvement. Okay, so that is what is the feature of the extramedullary tumors, right? Next, we'll move on to the next question. Next question is also the one which is related to the spinal cord. Clinical features of conus medullaris syndrome include all of the following except plantar extensor response, absent knee and ankle jerk, sacral anesthesia, lower sacral and coccygeal segment involvement. So if you see, what exactly is your conus medullaris and what is the cauda equina? Let me show you the differences between these two. So now this is the conus medullaris. What is that? It is the lower condensed portion of the spinal cord. That will be conus medullaris. Mainly, it constitutes the sacral part of the spinal cord. Whereas the cauda equina, it is the spinal nerves of lumbar and as well as the sacral. Together, that will be the cauda equina, right? Lumbar and sacral spinal nerves together will be the cauda equina. Now, let me tell you the differences between these two. So in conus medullaris, only sacral part is damaged, whereas in cauda equina, the entire bunch of the spinal nerves are damaged. Lumbar spinal nerves and sacral spinal nerves are being damaged in case of the cauda equina. Now, let me tell you the differences between these two. And you have to remember that in case of conus medullaris, majority of it will be bilateral manifestations. Whereas in cauda equina, majority of it will be unilateral manifestations, or there will be asymmetrical involvement. Right, there will be asymmetrical involvement in case of the cauda equina. Now, let me tell you the differences between these two. So, if you take the conus medullaris, right, it is sudden and as well as bilateral in onset. And cauda equina, as I have said you, it is asymmetrical or unilateral and it will be gradual in onset. And in conus medullaris, it is only the sacral part of the spinal cord which is commonly affected. That is the reason why the knee jerk will be normal, because the knee jerk, the root value is by your lumbar nerves. Whereas the ankle jerk will be your sacral. So the ankle jerk is lost in case of conus medullaris. But whereas in cauda equina, right, both lumbar and sacral spinal nerves are affected. So both ankle and knee jerk is being affected. Whereas radicular pain, that is root pain, Your cauda equina is nothing but the bunch of the spinal nerves. They are nothing but they also constitute the roots. So cauda equina, it has more severe radicular pain, but whereas conus medullaris, the radicular pain is less severe. Whereas if you take the low back pain, it is very common in case of the conus medullaris, but it is very less in case of the cauda equina. And if you take the sensory signs and symptoms, as I have said you, in conus medullaris, it will be usually symmetrical. In cauda equina, it will be asymmetrical. So in conus medullaris, the numbness, whichever is there, it is symmetrical and bilateral. Whereas in cauda equina, the numbness, it is asymmetrical and as well as unilateral. And same thing is even your motor strength as well. Motor strength also, conus medullaris, it is symmetrical, whereas in cauda equina, it is asymmetrical. And what will happen to reflexes? Conus medullaris, it is usually upper motor neuron involvement, whereas cauda equina, it is usually lower motor neuron involvement. So in conus medullaris, it is hyperreflexia, whereas in cauda equina, it is areflexic paraplegia. And what about impotency? It is very frequent in conus medullaris, whereas in cauda equina, the impotency is less frequent. And last and foremost, very important is regarding the bladder. In conus medullaris, remember always the bladder involvement will be early in the course of the disease, and there will be overflow, urinary incontinence and fecal incontinence. Whereas in cauda equina, you have the urinary retention, right? And the involvement of the urinary bladder in case of cauda equina will be late in the course of the disease. So in conus medullaris, the bladder involvement is early, whereas cauda equina, the bladder involvement is late. Okay. Now you see another question. Early loss of bladder control is seen in conus medullaris syndrome, cauda equina syndrome, Guillain-Barré syndrome, amyotrophic lateral sclerosis. As just now I was mentioning that in case of conus medullaris, there will be early loss of the bladder control. So these are the 5 questions which I have posted on the 10th of May on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So every day I am posting the questions, and on subsequent day I am giving you the explanation as well. So join my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, for daily quiz discussion. Thank you very much. See you tomorrow again.